introduction. It's a great pleasure to be here today to talk to you about a new program we are developing in Changhua. That's the computer-based health and precision healthcare in the Metaverse. And medicine have been involved significantly over the years. We moved from the one-size-fits-all medicine to the more personalized medicine that consider individual difference. And in the past, the one-size-fits-all medicine is the norm. That meant for people with the same condition will receive the same treatment or intervention. And then come the stratified medicine. We apply the risk factor, age, gender to divide the population into different groups. But the intervention was tailored based on the average risk of the group. Now we are entering the era of precision medicine. This approach uses a wide variety of individual level data and to ensure the right intervention to the right patient at the right time. And similarly, I will take the national colon cancer screening as an example. This screening program have to change to the next generation precision colorectal cancer prevention control. I will use this new program as an example to show how the precise medicine could be used in the population health. Sorry. And during past decade, because the national colon cancer screening has been planned for nearly 20 years, and the target population and the screening rate has been rising. And this rising has resulted in the increased demand for increased demand for the volume of testing and colonoscopy. And previous studies have suggested that when the lack of the screening capacity will result in when the capacity of the screening volume is not adequate to meet the demand of the rising target population and the screening rate, that will result in lower referral rate, reduced compliance with the referral, and longer waiting time for diagnostic colonoscopy, and finally to the poor quality treatment. Therefore, we could use the precision medicine approach, try to innovate, deliver the colon cancer screening. So we propose 4 strategies, try to reduce the workforce and time need for fit screening. The 4th strategy including invest in medical personnel equipment infrastructure, precision screening, and simplify workforce and eliminate manual step, and empower individual in self-management. And the fecal immunochemical test is the standard test for the national screening for colorectal cancer. And during the past decade, the most important finding is that we found that the baseline quantitative fecal ocular hemoconcentration could predict subsequent risk of incident colorectal cancer. As you can show in the left side the figure, the higher the concentration of the hemoconcentration in the fecal, the higher the risk of a colorectal cancer mortality and incidence. And this association represents a very strong dose response manner. So later, this study is conducted by the Dr. Chen about 10 years ago. Later, using the gradient relationship between the fecal hemoglobin concentration and the risk of the colorectal cancer, we could develop a personalized screening that try to change the interval for screening based on the hemo concentration. Because in the past, the national cancer screening for the colorectal cancer is biannual. For people have to receive the FIT testing every 2 years. So if we use the risk relationship between the concentration and the risk of colorectal cancer, we could change the interval. So this is a study by Dr. Yan-Ming Fang about last year. It's a published article that we use the fecal hemoglobin concentration guide screening interval. The number of fecal tests and colonoscopy could be reduced by 15% and 28% compared with the universal biannual screening. This suggests interval for different for HB concentration for different risk. You could see that for the lower risk, you only to provide the 3 to 6 years of interval for the cancer screening. And for the high risk, such as the people have a higher than 100% of more than 100 nanogram per microliter, you could provide each year or even 2 year screening for the people. By this personalized screening, we could use less demand for the volume of a screening test and the colonoscopy, but achieve similar outcome. By this design, we could calculate the people according to the CRC cohort of the National Cancer Program. You could see that more than 90%, most of the target population, they have a lower risk of colorectal cancer screening. Therefore, they could be allocated to the group of interval screening between 3 to 6 times per year. But for the high risk, the screening interval was suggested to be annually or biannually. And it should be noted that most of the people were belonging to the low risk group. So we designed this group as a usual care. And for the higher risk of 8% of the target group, we provided comprehensive health management for these 12 people. So how to implement the personalized screening program into real world? I will introduce it first. This is the current framework for colorectal screening in Taiwan. For each year, there are more than 1,500,000 participants in the cancer screening program each year. And around 60% of the participants receive their screening test at outpatient clinic of the medical setting. I call this opportunistic screening. And the remaining 40% of the participants receive the screening by the active invitation of the public health nurse in the health center. Is a way of organized screening. And totally, for this, every year, this participation of the cancer screening could produce nearly 40,000 pre-cancer and cancer cases each year in Taiwan. So when you want to use devise a personalized screening for this program, we adopted a pragmatic approach based on a biannual testing framework without increasing existing colonoscopy burden. The design is that we did not change the clinical part of the screening service. We just to change the pre-existing organized screening in the health center to a precision organized screening with active invitation by the health center. We changed this part, but remain the clinical part unchanged. So we could use the pragmatic approach to deliver the precision personalized screening for the people in the community. And how to implement the personalized screening in the real world. This slide shows the precision organized screening protocol for the health center. Based on the colorectal cancer screening registry and record of the hemoglobin concentration in the cohort, we could divide the group into two groups. The usual care group, most of the people have a lower hemoglobin concentration, will be divided into the low-risk group. And this group will receive a regular reminder and usual care. And the other group, the high-risk group, about 8% of the target population will receive comprehensive health management. The comprehensive health management have two parts. The first part is for those with the hemoglobin concentration 20 to 49. They will receive the active invitation and with biannual screening and active invitation by the health center, the public health nurse. And for those people with the hemo concentration or more than 50 nanogram per millimeter, they will receive a case management program to intensive to follow up to receive the annual screening for colorectal cancer. And for the high comprehensive health management high-risk group, they will be linked to the personalized health promotion and provided a supportive environment and health education as well. And why we should link, why we will link the high-risk group to the personalized health promotion program? Because various study has found that the baseline fecal hemoglobin concentration were associated with risk of cardiovascular disease and the risk of metabolic syndrome, oral cancer, periodontal disease, and also the environment pollution. And this association is accordant with the risk of the colorectal cancer because colorectal cancer are also a close related lifestyle factor. So the high-risk group as identified by the hemoglobin concentration is also the priority group for the intervention of to reduce the risks of CRC. So we combine this together to propose the personalized health promotion. And this shows the framework of the personalized health promotion. And this is the integrated person-centered approach that using existing multiple healthcare program in Taiwan. And this multiple existing healthcare program, including the lifestyle modification, such as the smoking cessation and betel nut chewing cessation, and supportive environment as a facilitator to empower the people. And also the chronic disease management as reimbursement by the National Health Insurance, including the disease management for the metabolic syndrome, diabetes, chronic kidney disease. And also including the self-management support service, including the health education, counseling, exercise instruction, nutritional counseling. And finally, also including the screening for the concurrent cancer and chronic disease, because some cancer and chronic disease is associated with the risk of the colorectal cancer. Combine this together, we could deliver a personalized health promotion for the people. And the next generation precision control, prevention control, as we propose, have three key components, including the computer-based precision colorectal screening and the personalized health promotion as I described. And the last part, I will introduce the Healthy Life, New Life program. That is a program to facilitate community-based self-managed fit screening in the community. This slide shows the current process of fit screening in Taiwan. For every screening service, the screening service begins with the pre-operation preparation and invitation. And when the people receive the invitation, they will go to the clinic or go to the health center to take the tube for fit testing. And after they take the tube, they will go to home. At home, they will take collect the stool sample. And then after the sample collection, they have a return the stool sample back to the clinic of the health center. And after the tube will return back to the clinic, the fit testing was sent to the laboratory for testing. And after the testing is complete, the participant has go to the clinic for the report. And after the doctor explain the report, they have to go to, if they have a positive result, they have to go to the hospital for further colonoscopy. And you could see that the whole process, the participant have to go to the clinic to take the sample and return to take the stool sample and return the visits and take the result and receive the report and therefore refer to the hospital for colonoscopy. And this process is very, is not convenient efficiency because they have the following barrier. The first, the service is very limited, only because only the clinical hour and medical facility, the people could receive the service. It's limited by the clinical hour and medical facility. The second, the participant require multiple visit to complete the screening result, as I have described. And in addition to the inconvenient process for the participant, the healthcare provider also is bothered by the cumbersome administrative paperwork, and the whole process is very labor-intensive and time-consuming because the process relies heavily on the manual process. So we devised a healthy new life program, try to facilitate this the computer-based self-managed fit screening. We propose following strategy. The first, we use online appointment scheduling. And second, we aiding pharmacy and convenience store to increase service flexibility. And we also use the online education self-managing for self-managed screening. And finally, the report was electronic and online delivered to the people and facilitate their online referral and screening colonoscopy. And this fourth strategy is supported by the centralized logistics for tube transportation and delivery, and also supported by the simplified workflow to reduce manual paperwork. I will show the real-world example how we conduct the new program. When the people, we will send a show message text, show text message and the invitation letter to the participant. When participant receive a text message and later, they could go to the web page to make an appointment for the fit testing. And after the choice, the place where they want to take the tube, they will receive a commutation message. And about 3 to 5 days later, they will go to the pharmacy to take the tube. And after the take the tube, there are video and pamphlet for the education, try to educate how to take the stool sample at home. Then they could return the tube to a smart box or a pharmacy. Then this tube was sent to the lab and for testing. After the testing completes, the participant will receive an electronic report and also an electronic coupon of $180 for encourage. And this healthy life have been conducted this year. You could see that around 3,000 people, 60% complete the process, and they collect the tube and return the sample without via the medical delivery channel. I draw to the conclusion, a practical real-world framework for the precision prevention and control of colon cancer has been established. This framework is built upon the P4 principle, predictive, preventive, personalized, and participatory. And ongoing effort will leverage extensive real-world data, advancing machine learning and metaverse technology to further enhance the program's effectiveness and efficiency. And this approach offers better insight for advancing precision population health in the future. The right side is a study by Dr. Lin, published article, using the digital twin approach to assess the over-diagnosis of face screening for colorectal screening. And the similar digital twin approach could also be applied to predict individuals' risk of colorectal cancer and to design and suggest the best intervention for the people, and therefore to reduce the risk of colorectal cancer. And we will use the digital approach later in our precision screening program for the colorectal cancer in the future. Thank you for your attention.
Thank you, Dr. Ye, for your wonderful presentation. Because the time limit, any question, we can take a question. Any question from our audience?
Regarding the hemoglobin test, is there difference between proximal colon and the distal colon regarding the sensitivity specificity of screening?
Yes, it's a different sensitivity and specificity for the distal and proximal colon. So for now, because the screening of the national program is universal biannual for all the people. So regarding the distal proximal, you could change the. There are some scholars try to change the cutoff point and interval screening, try to increase the maximum sensitivity specificity for the different location of colon cancer.
Thanks, Dr. Ye's presentation. Thank you.